Hello and welcome to our talk on common ENT presentations. Today we're going to be continuing on with stridor. Just as we get started, things to know that stridor is the harsh, high-pitched sounds of laryngeal and upper tracheal obstruction. Do not delay in seeing any patients that's referred to you with stridor. Even well-looking patients can deteriorate rapidly. You want to alert the registrar on call as well as the anesthetic team once you've got a confirmed case of stridor, and you'll need to stabilize the patient before getting any thorough history. Things that you'll need include your F&E scope with lubricating jelly, chlorhexidine wipes. You'll need phenyl ephedrine lidocaine spray, the blue spray, a headlight with tongue depressor, as well as a stethoscope. If the patient is stable, you'll want to get a history. If not, you'll need to proceed immediately to managing the patient's stridor, and the history can be collected afterwards. History in patients with stridor can be classified according to age groups. In neonates, these are usually congenital abnormalities that present within the first month or so of life. However, some can present further down the line. In infants to toddlers, the most common cause in this age group is croup or inhalation or aspiration of a foreign body. In young adolescents, this includes vocal cord dysfunction, peritonsillar abscess, and deep neck space abscesses. And in old age patients, these are down to either tumours or foreign bodies. But in all age groups, there can be a history of trauma, epistaxis, and foreign body. You'll want to rule out whether there's any history of epiglottitis or bacterial tracheitis that will present with severe respiratory distress and secretions, sore throat, and fever. If fever isn't present, then suspect a foreign body aspiration or anaphylaxis. In subacute patients, you'll often get children with croup that may present with intermittent stridor, and ask for any previous episodes of croup when you're interviewing the parents. You'll want to check for any accompanying symptoms, such as hives or swollen lips that may indicate anaphylaxis, any signs of cough, or any drooling, which may be an important sign of epiglottitis, retropharyngeal abscess, or foreign body aspiration. When examining these patients, you'll need to assess for any swelling of the soft tissues of the neck or the oropharynx, and check for any rashes or hives and any clubbing of the digits. Assess the tongue size, look for any pharyngeal edema or peritonsillar abscess, and assess the rate and depth of breathing. You want to auscultate for inspiratory and expiratory stridor. In patients that are stable, you can do a flexible nasendoscopy. Look for any signs of airway edema, supraglottitis, epiglottitis, and look for any masses or foreign bodies. Be careful in children. You'll want to consider avoiding doing a nasal endoscopy because this may lead to distress, which can exacerbate the stridor. You'll want to rule from your examination whether this is an infective cause or a neoplastic or anaphylactic cause. In patients with stridor, you'll want to start them all on high flow oxygen. Start them on intravenous steroids, either dexamethasone or hydrocortisone. If you're suspecting anaphylaxis, make sure that you give them IM adrenaline and IV chlorphenamine. They can also be given adrenaline nebulizers as well as saline nebulizers. They can also be given Heliox, which is a mixture of helium and oxygen, which will reduce the work of breathing if it's available in the trust. Once you've confirmed stridor, you want to consult with the anesthetic team and seniors, because then you may need to secure a more definitive airway, prevent this patient from deteriorating, and you want to do this early rather than later. Okay, thank you. This concludes our talk on patients presenting with stridor.